this respiratory system PowerPoint. And I'm going to go through it real fast. I just want to give a little overview. All right, my designated person, I guess, can be Kat, since I can't see any of y'all. Let me know when you can see my PowerPoint, Kat.
I can see it.
All right. All right, so the respiratory system. Oh, it won't even let me. Are you seeing anything other than the first opening page?
It has the first page, but oh wait, it just changed. It was kind of like a fade into the next slide kind of thing. But we also have arrows that we can use to change slides.
I gotcha. So if I start talking about another slide and y'all need to move it, y'all can turn the page, y'all can flip it. I'm having some connection issues. I don't know why. I have the same internet I always have, but it's giving me some problems. Okay, so as far as the respiratory system goes, everybody thinks lungs, but it's not just your lungs. Breath moves through the body by way of the nose, the nasal cavities, the pharynx, the larynx, trachea, bronchi, bronchioles, and then the alveoli. So when we're talking about upper respiratory system drugs, we're going to be talking about nasal sprays. We're going to be talking about stuff for our allergies, because I have allergies today, and y'all hear how nasally I am. That's my upper respiratory system that's giving me heck today. As I start to, as that nasal drip goes down, my larynx, my pharynx, my larynx is affected because I'm getting a little hoarse. My pharynx is my throat. So all of that is my upper respiratory system, okay? And then my bronchi and my bronchioles, that's when I'm getting into my lungs, those branches that are breaking off into my lungs. So we're going to talk about all the drugs that affect all of those things today, okay? So we know that the function of the respiratory system is to move air in and out of the lungs and exchange oxygen and CO2. This all should sound familiar from A&P. Right? We know that the nasal cavity is separated by a septum. So if we have a deviated septum, that could affect our breathing. And then we know that we have nasal mucosa, and within there we have ciliated epithelium. So if that's ciliated, if there is edema that's taken place in our nose, that is going to affect our respiratory system. So whenever we're talking today, just think about the way this is supposed to look, and think about how if we have a tissue edema on each side, when we give these medications, it's going to decrease that edema. So I just kind of wanted y'all to look at some of these pictures and refamiliarize yourself. We have the adenoids and the eustachian tubes, which are included in the nasopharynx. And then the oropharynx is where our food is going to be going down. The voice box is going to be affecting our, obviously our voice. So if we're hoarse, we would have laryngitis. We're going to talk about some drugs that may affect that stuff. All right. We're not so much going to talk about that right now. And then remember, we have our left and right bronchi that are going to open, and then they're going to open to the bronchioles, and then the bronchioles are going to make way to lots and lots and lots of alveoli. So when we're talking about our asthma medication and we're saying bronchodilators, I want y'all to get a good idea of what we're talking about here. We're opening up these bronchioles. When we talk about COPD, these alveoli are collapsed, and we're going to be talking about some things that affect that as well. So I really just kind of want y'all to just refamiliarize yourself with what these parts of the anatomy of the lung are. So the alveoli are the microscopic air sacs. They're surrounded by capillaries. They're coated with surfactant to decrease the surface tension. They have a single layer of cells, and they're made of elastic connective tissue. But with some of our disease processes, that elastic connective tissue loses its elasticity. So as we talk about these drugs, I'll be mentioning that as well. And then, of course, you guys know about the lungs. And so I wanted to point this out. So the respiratory muscles are the diaphragm and the external and internal intercostal muscles. So when we're talking about breathing or our patients are coughing a whole lot, be aware that those muscles can be sore. Be aware that those are some of the things that we're assessing when we're assessing these patients. And then our respiratory center is located within our brain. So we're also going to look at some medications. It has to do with our central nervous system. Some of the drugs that we're going to talk about are central nervous system depressants. So they're stopping that cough, but they could also affect our patient's breathing. So it's very, very important that we keep these, that we're assessing respiratory rate and that we're assessing, their patterns of breathing and all of this stuff. Just as you've already seen, just as much goes into assessment and evaluation in regards to given medication as does knowing the actual medication names. Because if you don't know how they're going to affect your patient and you don't know what to look for, what are you really giving them for? What are you really doing as a nurse? Because anybody can sling medicines, but you need to know what you're looking for and you need to know how they're going to affect your patient. Lung volumes, we'll talk a little more about using our incentive spirometer to encourage these patients who have respiratory problems. That's going to be one of our measures of objective data that we're going to use to see if they're improving. And we're not going to talk about anything about blood gases right now. Okay, so let me exit that and take just a minute. Did all that at least sound like you had heard it before in A&P? None of it was like brand new information. Don't feel like we're struggling before we even get started. Everybody feels okay. All right. So now let's go to chapter 31. Let me get that PowerPoint up. All right, y'all. Kat, let me know when you can see it.
I can see it.
Okay, perfect. All right, so before we go through our PowerPoint, I want to look at the key points together, and kind of that way we know what our goals are, what we're looking for in this chapter. So I'm on page 346. So we talked about the respiratory system briefly just now. We did a little overview. So you guys already know that things that can affect the respiratory system are going to be coughs. If we have a cough, obviously something's going on with our respiratory system, whether it's a nasal drip that's dripping down and irritating that cilia, or it's pneumonia. So cough is something that can affect. When we have a cold, when we're congested, when we just have stuffiness in our nasal congestion, that's going to affect our airflow, because remember I showed y'all the process. We're going nose, pharynx, larynx, all the way down into the lungs. And then, of course, allergies are a big one. that are common problems with the upper respiratory system. So when we talk about allergies, we can treat them at the source. So those allergies are, well, first, let's do this. I'd like to show y'all a video about antihistamines, because a lot of our drugs that we're using to treat upper airway stuff are going to be antihistamines because our body is having a reaction to, some kind of external stimuli, and it's reacting and it shouldn't be. So I want to show y'all a little video about antihistamines, and then we will, all of this stuff will make a little bit more sense, and then it's just going to be a matter of memorizing those drugs. So let me copy this YouTube link for y'all, and we'll watch it together. That way, when I'm saying antihistamines, y'all will be familiar with that as well. And if this is too much of a review, I'm sorry. I just want to go back to the basics to make sure that the drugs are making sense. Histamine, friend or foe? Kat, can you see this or no?
No, ma'am. Just see the slides.
I may not be able to play it for you guys. I guess I'll share it. Let me try one more time. Sorry.
Your camera's off right now, so I don't know if that has anything to do with it.
Do you see it now?
Yes.
Okay. Now just give me, I'm going to play and then I'm going to pause it again and just make sure that you can hear it, okay? Can you hear it?
No. It's very, very quiet. Like I can hear a tiny, tiny bit.
Okay. Well, I guess we'll just abort that and I will, I'll share it with you guys. The link is already on the PowerPoint. But basically histamines are, our body has these normal responses, right? And it sends messages to other parts of our body, and that's how our body knows how to respond to certain things. So histamines are substances found in various parts of the body, the liver, lungs, or intestines, and they're produced from the amino acid histidine in response to injury to trigger the inflammatory response. So they're like the messengers, basically. Let me get y'all back to my slide here. They are the messengers that are telling your body, this is not normal, do something, react. So like for those of us who live in the South, pollen is not necessarily harmful to us But whenever our body senses it, it lets off all of these antihistamines, and we are like, our nose starts running and our nasal passages start swelling and our eyes, we're all like just completely stuffy and have all this hay fever going on. Our body is trying to protect us. They're trying to be a friend, but then sometimes it ends up in turn making us more miserable, than if we weren't, if our body didn't release those histamines. So a lot of the drugs that we're going to be given for upper respiratory system problems are going to be antihistamines. So they're going to try to block those inflammatory responses of the body. We're going to try to block those in order to, so that we're not having that runny nose and that, that response, that histamine response. We're going to give antihistamine.
Miss Trailer.
Yes, ma'am.
We can't see your slide. It doesn't even look like your camera's on. It's just like the little circle with your initials.
I'll Mr. No today because I don't really know what's up. Ever since that day, remember when my computer kicked me out of Teams that day? Yeah. Ever since then, when I try to join our team meeting, instead of saying, when it says joining ... mine now says leaving ... and it won't say anything else. And I've uninstalled the application from my computer and reinstalled it, and it still says the same thing. So I'm joined from the web, and it's just different. So let me see. Let me try to pull up my PowerPoint again, and then I won't leave out of it since it won't let me flip around. Thanks for letting me know. Sorry for the technical difficulties. We should have went to class today, huh? Okay, you can see it now, huh, Kat?
Yeah, it's up.
Okay, so I really haven't even started on this yet. I'm still just reading from those key points. So intranasal steroids, and this is on page 346. Intranasal steroids and antihistamines are both used to reduce inflammation. That is their main job. They're reducing the inflammation. Decongestants are used to reduce edema and swelling. And antitussives are used to eliminate cough. So the antitussives aren't really working directly on any, they're not really fixing a problem. They're just suppressing that cough response, okay? And we're going to talk a little more in detail about these. A lot of these drugs will sound familiar to you guys, which is a good thing. So when congestion produces secretions in either the respiratory passages or the lungs, we're going to give other medications such as expectorants and mucolytics, and we're going to use those, and our purpose for those is going to be different. So based on what our problem is, based on if it's hay fever, we're going to give an antihistamine. If it's just a tickly, aggravating cough that's non-productive and we just want it to stop, then we're going to give an antitussive. So that's some of the things we're going to kind of be looking at today. What patients are getting what type of drugs? So many of the products that we're going to discuss are obtained over the counter and do not require a prescription. But because of that, it's very important. People think that if you can buy something over the counter, it's not dangerous. Is that true?
No.
It's not true. If it is, it still has to be taken in the correct quantities, or it can kill you or damage your liver or cause all kinds of issues. So our job with a lot of these is if your cough persists and you've been taking an antitussive for 17 weeks, then maybe we should evaluate this cough. Maybe your body's trying to tell you something. So a lot of our job as a nurse for these patients, even though the medications are over the counter, is going to be to educate and make sure that they know that they can't just take these things constantly, and that even though they're not prescription medications, that we need to let their doctor needs to be aware that they're taking them. if they're not aware, so let's say you haven't learned about these medications yet, but let's say your patient is taking something to suppress their cough. It's aggravating them. They don't want to cough anymore, but their doctor wants them to cough. Their doctor is wanting to thin out that mucus and cough everything up. Those two medications are going to counteract one another. Does that make sense? So the patient has good intentions and the doctor has another plan, and nobody's communicating to say, hold on, let's reevaluate and see, let's see what we need to do here. And then the last thing is going to be our patient safety. Antihistamines can produce drowsiness, and other medications, combined with antihistamines can be dangerous. So we want to make sure that they are remaining safe, and that in taking these medications, they're not developing any kind of symptoms that are going to put them in danger, that they're not driving sedated and stuff like that. So any questions before we move on to these slides? Because the respiratory drugs, it's a lot of drugs, but the concept should be easy for you guys. It should be stuff you'll already know. So questions before we move on? You good? All right. So common conditions of the upper respiratory system. They can be caused by infections, allergic rhinitis, which is runny nose related to allergies, coughs, the common cold, and congestion. So if you notice that pneumonia is not on here, and asthma is not on here, and emphysema, COPD, are you guys noticing that they're not on these slides? Talking to myself. I know y'all are all muted. Somebody talk to me. I don't care who, because I can't see anyone. So I feel like I'm lecturing to myself too.
What was the question you asked?
The question was, these are common. I have listed common conditions of the upper respiratory system. Asthma is not on here. COPD is not on here. These are all have something in common that's not related to that. Why do you think those aren't on here?
Maybe not because everyone gets it.
Good guess. So we're talking only right now about the upper respiratory system. All of those conditions affect the lower respiratory system. They're affecting from the bronchi down. So I want y'all to keep these two sets of drugs separate, because your patients who have just a random cough are not generally going to be prescribed medications that affect, the lower respiratory system, unless their cough is caused by a different, by a condition that's rooted within that lower respiratory system. So right now we're talking more, stuffy nose, swelling of the throat, tickly cough, common cold type stuff, drip, upper airway stuff right now, okay? So the medication classes that are going to go, if we were making our umbrella and we said upper airway medications, upper respiratory system medications, our little branches off of that would be antihistamines, intranasal steroids, decongestants, antitussives, mucolytics, and expectorants. And all of those little subclasses can be found on page 346 on. Now, as far as antihistamines, I will not ask you guys the difference between the first and second generation antihistamines. But I do expect you to know which drugs are antihistamines. And I want you to know the difference, when we'll get to that in a second, of why the second generation are a better option. They don't cause as much drowsiness as the first generation antihistamines. So those first generation antihistamines are going to be given still, but we're going to be a lot more concerned about the drowsiness that is caused by those. like Zyrtec, I took a Zyrtec this morning because I told y'all I was stuffy. I can still function to lecture you guys. When I take Benadryl, I'm knocked out like the whole day. I'm worthless. Benadryl is a first generation antihistamine, and Zyrtec is a second generation antihistamine. So those are the first class of drug. Intranasal steroids are going to be our nose spray. And those, almost all steroids end in NIDE or SONE. All right, we have our decongestants. Those are found on page 347. So that's the main ones out of that are going to be like your Sudafed, and neosynephrine. So Sudafed we know has to be purchased behind the counter now. So that's pseudoephedrine. Phenylphenephrine is the neosynephrine. That's the one you can still buy over the counter without. They're both still over the counter, but they don't keep the neosynephrine behind the counter where you have to show your driver's license and all. And then you have nasal sprays that can be decongestants, such as Afrin. And then any of those, the Claritin, Zyrtec, those antihistamines up there, if they have a D after them, then they have pseudoephedrine in them, which is a decongestant. Okay, so a lot of your drugs will be combination drugs. Y'all following me? I'm just kind of going through the medication list so y'all can understand it. There's some more decongestants on page 348. All right. And then you have antitussives, mucolytics, and expectorants. So codeine is a antitussive that's used, and it suppresses a non-productive cough. So remember we talked about the respiratory centers in the brain briefly having to do with our breathing. They also have to do with our cough reflex. So when we give that opioid antitussive codeine, it suppresses the cough. So when we're giving that medication, we haven't learned about opioids yet, but we have to let our patient know that it can be habit forming. We have to let them know to take it as directed. And we have to be very cautious that our patient isn't, constantly saying that they have a cough or wanting these medications. They are not prescribed as freely as they once were. So codeine is an opioid antitussive. And then non-opioid antitussives are Tessalon pearls or benzonatate. Let's see. And then, you have your pertussin, your over-the-counter stuff with your dextromethorphan. That's page 348. And then like ZQuil has a little bit of diphenhydramine in it, which is Benadryl, which will suppress that cough as well. And then you have your main expectorant is Mucinex. I know y'all are familiar with that, guarafenicin or Mucinex. So we're going to have to, the way that we made our charts for our mini drug classes that we had for our heart medications, y'all are going to have to make those charts for these drugs too, okay? Okay, and then they all work differently. The antihistamines relieve the allergy symptoms. The decongestants reduce the nasal edema. And then the antitussive, mucolytics, and expectorants are specific to that cough. So I'm going to let y'all watch this video on your own. We do that after our lecture. It's like 5 minutes. It's the one I was trying to show you guys at the beginning of class. But basically, I did tell y'all what histamines are. So antihistamines will block most of those histamines, but not all of them. Okay, so they can be first generation or second generation. And they will bind non-selectively to central and peripheral H1 receptors and may result in CNS stimulation or depression. They are not only used for those allergies and the histamines, they can be used for itching, they can be used for nausea. And then the second generation antihistamines as a whole are much less sedating. So you see right here, I left this, I'm trying to give y'all some study tools as we go. When you're studying, and I told y'all to try to practice like teaching, try to say, these are the antihistamines, and this is the difference between the first generation. An example of a first generation would be this. An example of a second generation would be this. I want y'all to try to fill those things in as you go, as you're studying. And I said I didn't want you to know the difference between them. I guess in a way you have to, because you need to know, as far as educating your patient, which ones are going to cause drowsiness more so than others. So I guess I'm gonna have to take back what I said. You won't have to know when we move on to the excuse me, I'm sorry, I can't think. Antipsychotics. I won't make you know the difference between first generation and second generation with those. Okay, so we know that antihistamines, we've probably all taken some Benadryl or Zyrtec or Claritin in our life, that we use them for seasonal allergies, for rhinitis, for conjunctivitis, for mild or uncomplicated angiourotic edema, so eye swelling and urticaria, allergic reactions to drugs, blood, or plasma. So when we start talking about blood administration, a lot of physicians are going to pre-medicate your patients, meaning they're going to give them an antihistamine as they're getting their blood to kind of block those histamines from the start so that we don't have a reaction. And then we'll use these antihistamines for coughs caused by colds or allergies. We will use them as adjunct treatment in anaphylactic shock. So if someone is having a severe allergic reaction, we're going to use these antihistamines along with some other medications. So one of, let's see. Never mind. We're going to use them in treatment of Parkinsonism. So if people have certain, some like tremors and different stuff like that, we'll look up Parkinsonism in a little bit, but it's, certain signs like, tremors of the hands. Sometimes these antihistamines are used for that. Relief of nausea and vomiting. So I've been my kids get very car sick. And I've been in situations where I didn't have any Dramamine or whatever. Benadryl does work for nausea, especially in the cancer world. When we are treating our children for, when I did hospice, they would usually give them a cocktail, and it would include Benadryl along with some other medications. Relief of motion sickness. We'll use them sometimes for sedation along with other medications as we're putting patients to sleep. And we'll use them as an adjunct to analgesics. So sometimes we will give a pain medication plus an antihistamine, such as Phenergan, and that will help our patient to relax and, it'll allow their body to relax, and it'll also allow that pain medication to take effect. Okay, so antihistamines, drowsiness and sedation, and disturbed coordination. Those are very important to remember. With those being the side effects of antihistamines, your job as a nurse is to do what? Somebody tell me. If we know it's going to make them drowsy and sedate them and cause them to have disturbed coordination, what is our job?
Do you check on them like every 15 minutes?
So yes, you're checking on them frequently. So 15 minutes would be, a little bit, I guess, excessive. The main thing is safety. If our patients are drowsy, so were you talking about checking on them frequently because of their respiratory status?
Well, I think I was thinking that because we just learned about surgery. So I was thinking
Gotcha.
like you would have like bedside rails up, the bed block.
Yes. So making sure that if you're administering, especially if you're administering them IV, that you would be looking for some of those safety measures, just like you said, bed in lowest position, the side rails up. Now, if they're taking them orally, people take Benadryl and they function every day, but you just need to let them know, this medication, it's over the counter, but it affects everybody very differently. So, if it's your first time taking this medication, see how it affects you before you go drive down the road. Y'all see what I'm saying? Like your patient just needs to know, they need to know what to expect, and they need to kind of have a heads up, so they can plan their day. You may not be able to carry a meeting on if you take this medication, because you'll be like, kind of like I am this morning with my Zyrtec. Because it will slow their responses down a little bit. It'll decrease their coordination, and it'll just make them tired. It will also cause some anticholinergic effects like a dry mouth, dry nose, dry throat. So sometimes it's working, it's drying up that nasal drip and those runny eyes, but they're, sometimes they'll have nosebleeds because their nasal passages get overly dry. Those are things that you need to let them know. Keep me posted on this, so we can let the doctor know and we can reevaluate. If you went from having, sneezing 700 times a day, which was miserable, and you started taking this and it was working, but now you're having nosebleeds every day because your mouth is and your nose, because your nose is so dry, maybe we can either find you a medication to moisten those nasal passages, or we can back off the Benadryl. But if you're not gathering that information from your patient, then you can't get them what they need. Does that make sense? All right. So the antihistamines, the first generation, and like I said, I apologize, you do have to know the difference between the first and second generations. I spoke way too soon on that, and I'm sorry. The first generation antihistamines, we don't give them to pregnant women generally. We don't give them to individuals who are taking MAOIs. We don't give them to patients with peptic ulcer disease where it's stenosing, where it's narrowing. And we don't give them to anybody with bladder neck obstructions or BPH. If people are already having problems with urinary retention, we're not going to give them these antihistamines because they have an anticholinergic effect. And y'all will learn more about anticholinergics later, but basically they're going to dry everything up, and they're going to worsen their problems with the stenosing and those obstructions. They're going to worsen those problems. So the second generation antihistamines, we're not going to give them to patients with known hypersensitivities to the drugs. And sertrazine, that's Zyrtec, is contraindicated in patients who are hypersensitive to hydroxyzine. So I want to show you guys, trying to find it, hold on. see it in here. If y'all look, see where it says uses. So hydroxyzine is a medication. I don't even see hydroxyzine in here. If anybody sees it, let me know. Visceral is the other name. I don't even see it in y'all's chart. So hydroxyzine is a medication that is going to be given to a lot of our renal patients, and it's going to be given for itching. So a lot of times they won't be having an allergic reaction, our renal patients, but all of the toxins in their body that they can't get rid of causes excessive itching, and hydroxyzine is given for that. And then antihistamines overall are going to be, now this does not mean that they are never given, because they are given, but they're used with caution in patients who have bronchial asthma, cardiovascular disease, glaucoma, hypertension, impaired kidney function, and urinary retention. So the whole thing about that, let's go. I want to show you guys. Let me go back to chapter 25. Give me just a second. Okay. So if you go to page 299 in your book, just so I can make y'all understand why these medications are used cautiously with these patient populations. Cholinergic blocking, the Benadryl it's an antihistamine, but remember I told y'all in the beginning that drugs can be in two separate drug classes. So it can be an antihistamine, but it can also be something else. So Benadryl is an antihistamine, but it's also a cholinergic blocking drug, which means that it blocks some of those normal, the parasympathetic branch of the autonomic nervous system is going to, send your body into that mode where we have the fight or flight, or we have the rest and digest. So the parasympathetic branch of the autonomic nervous system regulates both voluntary body functions and skeletal muscles. The anticholinergic drugs block the neurotransmitter acetylcholine. So the anticholinergic drugs that are blocking this can have an effect. They're blocking one thing to dry stuff up, but they also, in that parasympathetic response, can affect the bronchioles, and they can affect the bladder neck, and they can affect all of those other body systems that are normally in relaxing mode. As they're drying up, they can tense that stuff up. So that's why they can worsen glaucoma, because that's pressure behind the eyes. They can worship symptomatic prostatic hypertrophy, that's BPH. That's kind of like hypertension near the prostate, impaired kidney function, and those peptic ulcer tightening and the duodenal obstructions. They can, in the way that they work, because they're drying things up and because they're having an effect on that response of the body, they can also affect these other things. So I just kind of wanted, y'all don't necessarily have to remember that, but I wanted y'all to put a connection, like, where is all of this stuff coming from? What does it even have to do with asthma or glaucoma? Those are kind of secondary things that are happening as the body is having that cholinergic response. Was that over y'all's heads? Are y'all okay? Y'all type in the chat bar. I can see my chat bar. I need to make sure y'all are all still with me. Y'all are okay. overwhelmed. Okay, I figured y'all are being super quiet. All right. So let's. I'm gonna tell you some of these interactions and we're gonna take a break for a second and regroup. So yes.
Your audio is so weird right now.
Yeah. Am I back to normal or not really?
I don't know about y'all, but it sounds like a robot.
Every the whole time I'm talking or just recently?
It just started.
Okay. Is it back to normal or not really?
No.
Okay. Is that better?
No, man. No.
Okay. All right. So probably let me do this. Let me, because I'm recording this for another class too. Let me just read this last slide with antihistamines, and then I will disconnect and get back on. So these are just the antihistamine interactions. Just like all of our other drugs, we can have drug interactions. So antihistamines are the same. Especially pay attention to the they can add to the CNS depressant effect. So we know that they're making us drowsy. If we're given something else that's going to make us drowsy, it definitely may make it worse. I'm going to disconnect here, and then I'll join right back, and we'll pick up after the antihistamine regroup. Okay.